Hello, and welcome to this Medicine Matters Rheumatology podcast. I'm Claire Barnard. In this series of podcasts, we are looking at the repurposing of rheumatology drugs for COVID-19. This episode focuses on TNF inhibitors, and we are talking to Dr. Philip Robinson. Philip is a senior staff specialist at the Royal Brisbane Hospital and associate professor at the University of Queensland, Australia. He is chair of the steering committee of the COVID-19 Global Rheumatology Alliance. Emerging data, including from the COVID-19 Global Rheumatology Alliance, have suggested that TNF inhibitors could be promising agents for COVID-19. First of all, Philip, could you explain what the rationale is for testing these agents as potential treatment options and outline what some of the studies have shown?
Yeah, so thanks for that question. So the rationale and what the studies have shown are really one and the same. So there have been two really major registries that have collected data that support, and there have been a few other smaller studies. The big, largest registry that I'm involved in is the COVID-19 Global Rheumatology Alliance. So we currently have around 10,000 patients in that registry, but we've published a study looking at the outcome of hospitalization in May of last year, where we used no treatment at all in rheumatic disease patients and found the protective effect. So reduced odds of hospitalization with those people on TNF inhibitors. And it wasn't a small effect. It was around 0.3 or 0.4, depending on how you looked at the data. Now, there's certainly limitations to voluntary registry data like that, but it's a pretty strong signal regardless, and it's worth thinking about, and certainly that's precipitated others to think about it. And then the other registry that saw a similar effect was the Secure IBD registry. And they've been collecting worldwide cases of of inflammatory bowel disease. And they also saw a protective effect in some of their outcomes, but not all of them. And they had 525 patients. And they didn't see the protective effect on death, but some other composite outcomes. And then there's some other smaller studies around that have shown better outcomes, those who are already on TNF inhibitors and get infection. So essentially, that's what's been the reason that people have started to look at this issue or look at this medication. And then when you look at the medication, there are a number of factors that really support why we might be seeing this in patients. And the fact is that TNF is a key inflammatory mediator. It drives a number of other mediators, including VEGF, which is a mediator that promotes vascular permeability, so would contribute to things like pulmonary edema. It also drives a number of things, including coagulation, and that's something that we see in COVID-19. So if we look way back at the mechanistic data, there's certainly a lot of support there. And then there's also support in the middle from animal studies. So when you put TNF into models of SARS-CoV-1 and SARS-CoV-2 and also a number of other viral infections, you get better outcomes. So reduced death and reduced weight loss, which is a key outcome that we see in mice. So sort of all along that pathway, we see data that supports, in theory, why we would see that effect in humans.
Where are we at with clinical studies in people with COVID-19 and who don't necessarily have IBD or rheumatic diseases?
There has been one small case study or case series published, and there have been a number of smaller case studies showing that people have better outcomes. But essentially, that is what the registry data is. It's just a ginormous case series. So it doesn't sort of support those. But there is a case study of patients being treated with TNF inhibitors in hospital, and 6 out of the 7 of them had better outcomes. Now, that's a non-controlled study, but thinking about controlled studies, the Catalyst trial in the UK has, my understanding is that have completed recruitment into the infliximab arm, which is around 60 patients. The results of that have not been released yet, but that's probably going to be the first cab off the rank about what we know about this. There's the Active-1 trial in the US, which is aiming to recruit around 2,000 patients, and they're using infliximab in patients. And then there has been a release from the Department of Defense that they were doing a pre-hospital, or they're planning on doing a pre-hospital adalimumab trial. The details of that are not public, but certainly that's going to be another large trial, I understand.
So in your opinion, do you think TNF inhibitors should be prioritised over other agents for treating COVID-19? And if so, why?
This is a very interesting question, because the mechanisms and the logic made a lot of sense for IL-6 inhibitors, and they got a lot of early press and a lot of studies, and that made total sense. It's sort of essentially, I could have been talking about IL-6 up to this point. But then the early studies were underwhelming. They had some improvement in outcomes, but not improvements in death. And then the later studies, we saw some of that. So, what does that mean? And I think it's a very interesting question. Like, why do we see some studies with, similar inclusion criteria coming out with different outcomes from those? And I think that this, the devil is in the detail, I think, is what the outcome is what the simple upshot is that we're talking about different patients with complicated comorbidities and age, and then you chuck in this thing that is really difficult to get a handle on, and that is disease stage, because you get patients that sail through with no symptoms, and you get patients that sail through with a snuffy nose, patients that end up intubated and ventilated and they die. Now, when a patient turns up to hospital, they're not asymptomatic with a snuffy nose, but they're somewhere beyond that point. And so when you take those patients and you stick them in a clinical trial, you're getting a massive heterogeneity in the disease stage, and we don't understand. I don't think, and I think other people would agree, that we don't understand enough about how to stage disease to really be able to go, okay, well, I'm pretty confident that I've got a pretty tight group here. They're all in the more than minor stage, but not in the severe stage. I mean, how would you measure that? You measure that by, biomarkers, but, people respond differently. So I think it's very encouraging. And I think if we get the number of studies that we have seen in IL-6 and TNF, then we may well get a better idea about how this fits in. I mean, of course, they may all be negative or they may all be positive, but I think that's rose-tinted glasses. I think you're more likely to get an IL-6 type picture, where some studies are going to be more helpful than others, and then it's going to be potentially about things about study selection, study design. The thing that I would say is that, we can speak in the same way about IL-6 inhibitors, is that it's a complicated landscape, and the clinical trials that have been done in IL-6 have largely been in very unwell patients. And the registry data that is supportive of the use of these agents is in patients that don't even have disease yet, and then they get disease. So I think we need to be really careful about study selection, about study design, and about interpreting the results of study outcomes. Because if you take a group of very unwell patients and you give them IL-6 or TNF, that is a very different scenario than having someone who's been on TNF for months and months or years and years, and then they become unwell, because the inflammation state is already well on the way when you start giving these agents. And it's not just stopping them becoming inflamed, it's trying to turn off and turn down this hyperinflammation state. So I personally think that these studies that are likely to have the best chance of success are the ones that use these agents early. And that is what the Department of Defense have said that they're going to be doing in their release, in their press release. So I suspect that that is going to potentially have more chance of success than the Catalyst and the Active One trial, which are using intravenous drugs in patients who are very unwell. So this all comes back to the devil's in the detail and where we at as far as disease severity. And if you get people who are very mild or on the milder end, but are showing signs of ramping up their inflammatory response, I think that we're going to see the best responses, because we're hopefully going to shut off that hyperinflammatory response before it even starts.
How do you think rheumatologists need to be involved in these studies of TNF inhibitors as people who have a lot of experience with using these drugs?
So I think that's really important. There was some really nice data published in Boston, out of Harvard, showing that really the minority of patients with rheumatic diseases who got admitted with COVID to hospital had their rheumatologists involved. And I don't necessarily think that's surprising, because there's very limited relationships between intensivists and rheumatologists up to this point. But I think it's a shame, because we use these drugs and prescribe them every day, and we're very familiar with the ups and downs of them. And so my thought is that it's critical that rheumatologists involved in this type of study, because COVID is a global disease, and there are problems with these agents that are outside of the Western affluent world, like TB and those sort of things. Now, I'm not suggesting that TB is an issue for a very short-term use of a TNF inhibitor, because I don't think it is, but it's TNF molecules, and their use is a complicated thing, and we've got a lot of experience. So I think having them involved, and I know that they are involved in a number of these trials because of the experience that we do have.
So how about patients with rheumatic diseases? Do you think that the investigation of these agents is going to have an impact on rheumatology practice for people with rheumatic diseases who don't necessarily have COVID?
Well, I think it's going to be interesting, because up to this point, pre-pandemic, there was a big focus on, and then at the start of the pandemic, about really how these drugs were going to potentially be detrimental to patients. Then as the stories came through and the registry data accumulated, it looked like, in fact, that rheumatic disease patients, overall did pretty well. There are a few exceptions, often targeted at things that people don't really have control over, like their comorbidities, and a few specific therapies, for example, rituximab. But in the main, most rheumatic disease patients do okay. And is that about the fact that these people are walking around on immune system moderating agents, when the thing that kills you in COVID is hyperinflammation? There are a range of things that kills you if you die from COVID-19, but one of the major factors is a hyperinflammation state, and these people are walking around on medications that control their immune system. So I think that's potentially reassuring if we then do clinical trials and show that there are not poor outcomes in the agents that these people are walking around on. They don't necessarily have to be concerned leaving their house and going to the shops. They can say, well, these drugs are actually used to treat people, and I'm walking around without it. So it's not necessarily a tangible thing, in that you can speak to people and reassure people about their mental health and about that they're not at extreme risk.
Looking to the future, Philip is optimistic that TNF inhibitors could have a positive impact on the care of people with COVID-19.
I just very much hope that we're going to we'll get some answers. Clearly, I would love it for all the COVID to go away and this trial to become irrelevant. But if COVID's still here, and I suspect that's going to become endemic, then it would be lovely if we could get some answers, because these agents are in widespread use. There are biosimilars. They're produced, across multiple countries. These are not niche, highly expensive agents with very limited supply. They're in every single corner pharmacy. And so if we can show that these drugs are effective, then the potential to immediately apply them in clinical practice and save lives is really, really exciting. So I think it's not just about mice and animals and mechanisms. There's a lot of practical, very pragmatic aspects to why TNF and in fact IL-6, if early IL-6 agents show promise, why these things are a much better bet to be thinking about than niche products.
Thank you very much to Philip for sharing his thoughts, and thank you for listening. This podcast was produced by MedWire News for Medicine Matters Rheumatology. Please subscribe for more podcasts on COVID-19 and rheumatology practice. Medicine Matters Rheumatology will also be covering research and guidance on COVID-19 in patients with rheumatic diseases. Keep an eye on rheumatology.medicinematters.com for the latest news.